Thank you. Thank you, Dr. Shobha, and thank you for asking me to be here. Subject close to my heart. Always important for all of us to worry about what's happening to our aging brains, and I'm more than halfway there. And there are many of us in this audience who might wonder what things will be like a decade down the line. So in clinical practice too, in my practice when I started as a young neurologist and the way I see patients now, there's a much larger number of elderly individuals seeking help for part of their neurological networks that are failing. And it's a big conundrum as to what are we getting wrong. If we are healthcare workers, then we ought to be able to guide people in maintaining health. Unfortunately, in my reckoning, I think we are very good disease care workers, and perhaps we need to relook as to what we can do about healthcare. Let's jump into what happens to patients when they see us for failing cognition. Traditionally, the domains of cognitive functioning that neurologists and psychiatrists are taught is that there are 6 domains of cognitive functioning that we need to be aware of and we need to assess when someone comes to us and says that my memory is not so great. So one is memory, the other is visuospatial skills, the third is language, the fourth is personality and behavior. Then there is praxis, which is often not mentioned in the traditional model, and we'll come to that in a bit. And a lot of this is vitiated by attention. And in today's age where everybody is on the phone and while I'm speaking here, you'll watch that a large number of people will still be checking their messages. So attention is gradually being eroded by the pressure to be with the device. And that is also a problem, and then it can be pathological in some individuals who have cognitive impairment. So along with that, then there's praxis. So praxis is the ability to perform a complex, learned, coordinated task without having to focus on its individual components. And this is ingrained, but often in moderately advanced dementia, you will see patients having difficulty with praxis. So the reason why we try to understand things, the reason why the methodologies in which we try to understand this is that we have put anatomical boxes because our basic neurological learning came from gut brain traditional science. So we have a frontal lobe, we have a parietal lobe, we have a temporal lobe, and we have an occipital lobe. And we know that these parts of the brain are constituted by anatomically slightly variable, but in different ways, 6 layers of the cortex, which have a complex function of creating a construct for neural networks. And these cells are now known, and we know that in some disorders, some of these cells are specifically dysfunctional at an earlier time in the evolution of a cognitive problem. And most of us, when we were in med school, at least when I was in med school many years ago, we were told that the glial cells were traditionally what Ramon y Cajal said, that they are glue cells. They were meant to stick the neurons together, and it's the neurons that do all the talking and all the work. Now we know that things are different. We know that the astrocyte and microglia have a very important role to play amongst the glial cells. They have a very important role to play in maintaining the healthy balance of physiology in the brain, both in terms of metabolic work and in terms of cognitive profile. So if there is an anomaly in microglial function, so if you have a mutation, say, in the TREM2 gene, then your macroglial function can be abnormal, and you can suddenly have microglia that are overactivated and producing cellular loss rather than neural recovery. And we'll learn a little bit about that as time goes by. I'm sure Aditya is also going to talk to you about it. And we now know that there are specific forms of astroglial dysfunction that can also produce cognitive impairment. And the neurobiology of cognition is therefore changing. For us to understand, we need to know that neural networks are the way clusters of neuronal cells talk to each other. And there are differing networks for differing cognitive domains. And when one is not doing a focused attentional task, as for example, listening or talking or speaking or writing or performing a goal-directed behavior, then there is a default mode network. And in this slide, what you can see is the default mode network shown in purple. So the default constituted by the medial prefrontal cortex there, the posterior cingulate gyrus, parts of the dorsolateral cortex are not involved here, the lateral parietal cortex and a bit of significant bit of the temporal lobes. So there is a growing notion that this default mode network is the network that is being used constantly, not only when we have goal-directed tasks, but even when we are not doing a goal-directed task. And perhaps that could be one evolutionary susceptibility that many of these abnormal proteins that accumulate in the brain in a degenerative brain disease, many of them will be discussed by Dr. Aditya, have a susceptibility to these parts of the neuraxis where they accumulate. So if you ask the question is that why is it that tau and amyloid has a susceptibility to involve specific loci within the anatomy of the brain? And one of them could be also the amount of work that they are doing through a lifetime. And we don't know that. Nobody's really worked that out. So when you and I are clinicians, we don't do basic science. Patients come to us with their medical problems. Why do elderly people seek medical help from a neurologist or a psychiatrist? The commonest is a symptom for doc, my memory is not so good. So the commonest is problems with forgetfulness, and this can start in the 60s, or it can start in the 70s, or it can often start in the 80s, depending on who the person is. The second common problem, often which is not recognized by the patient, but which an astute clinician will recognize, is problems with language. So the dominant problem can be word finding difficulty and can also be altered comprehension. So the person is being spoken to, but they don't really understand what's been said, so they ask you to repeat what they're saying. And a previously verbose person has word finding difficulty and starts using words which may not be in their repertoire as before. So there are lots of theories about this. People believe that Agatha Christie, if you look at her first novel and her last novel, in her last novel she clearly exhibited the signs of late onset sporadic Alzheimer that she had in her linguistic use of her repertoire of words with which she described her stories. So this can be an issue, and again neuroscience is trying to come to terms with this. There can be problems with personality and behavior. So we know that our behaviors are governed by social regulation, so there are rules of social propriety. We know that we achieve goals through goal-directed behavior, and that requires judgment, knowing the effects of cause and its actual outcome. And this again translates into financial transactions. So often the first symptom that may emerge in a cognitive story is that this person, who was a very balanced individual, has now started failing in social behavior, has started failing in financial transactions, and is exhibiting change in their executive functioning. We'll come to that in a bit. And of course, visuospatial orientation. So our ability to understand space and time, and our ability to recall geographic cues from within our immediate environment, our environment in the locality, and in environment in cities and places that one has visited before. So that constitutes visuospatial skills. There will be a story of getting lost in familiar surroundings, geographic amnesia, and often this leads to disorientation. So these symptoms again need to be understood. There is the place where all psychiatrists come into play. Most of the times elderly people can often start with what the family notices first. They have said forgetfulness is just because of age. We know the Hindi term, it's called Satya Jana, my age, 60. Once you're 60, you are allowed to forget. So they have this term in Hindi called Satya Jana, it comes from 60. But I think that 60 is now moved to maybe 75. Having said that, often patients don't go to a doctor because their elderly person is forgetful. They go to a doctor because they have changed their reality synchronization. So there may be a history of delusions, paranoia, hallucinations, and illusions. And I've purposely kept illusions last because I've never seen a symptomatic presentation of illusion. Most of the times it's with paranoia, delusional behavior, and in conditions like Lewy body disease, vivid visual hallucinations. And then there can be problems with praxis. So if you have an astute family member, they will notice that this person now finds it difficult to twiddle with the remote of the television and get onto Netflix and watch a movie of choice because they don't know what to do with them and they have problems retrieving their WhatsApp messages. So praxis, using gadgets, driving, personal hygiene, dressing can all be a part of it. And there can be problems with language, we said. In the non-dominant side, that language dysfunction can manifest as change in prosody and not with actual linguistic components. And there can be problems with semantic knowledge and there may be limitations in how they perform because they don't know what a book does and they don't know what an actual, say, cooker does or maybe a grinder mixer in the kitchen does. So one may have problems with semantic language and this is compounded often by coexisting symptoms which we never ask about. And these are symptoms of physical frailty. And in my experience, a lot of these elderly people who are seeking our medical help have symptoms of physical frailty. They have problems with balance, they have weak musculature, and they have problems navigating structures like a simple getting down the steps. And hence, they are susceptible to falls, they break a femoral bone, and you get a story that she was fine or he was fine till he actually broke his femur. And doc, within 6 months, he or she is no longer the person they used to be. So it's not the femur that is at fault. It is the coexisting problem. And we'll talk about this in the end. We talk about prevention. So there are theories now that dementia starts in your legs. People are talking about that. It's not really that dementia starts in your legs, but if you have strong core musculature, then your susceptibility to dementia is less. That's one of the take-homes that we should take. So what is this? What do we do in the clinic? I think in the clinic, what we are doing is pattern recognition. We are looking at the stories, and they are saying, hey, what does this tell us? So we are trying to discern patterns, just like a hunter who's looking at the spoor of an animal and saying, okay, this was a badger, this was a lion, this was a leopard, this was the elephant. We are trying to make sense of the entire gamut of cognitive symptoms that patients are telling us and trying to say that what does this mean? And these patterns coalesce into an entity. And many of these primary entities like frontotemporal dementia, Lewy body disease, or Alzheimer's disease, Aditya is going to walk you through those patterns and tell you how there may be commonalities in the symptomatology, but the evolutionary pattern can be different. And by understanding an evolutionary pattern, one may be able to arrive at a working diagnosis of what you think is the underlying problem. If that's to be the case, then what do you really need? You need a good history. And for that, you need background knowledge. And this history depends on us. Patients don't know what they have, so they will tell you what they perceive, and that's from lack of neurological or psychiatric knowledge. We are the erudite ones, we need to take the good history. So if on a history, patterns will emerge. So something that looks very fuzzy, you don't know what it is, the pattern will actually come through and will tell you, hey, this sounds like frontotemporal dementia. This one sounds like diffuse Lewy body disease. So we need to know language, personality, praxis, visuospatial skills, and executive functioning. So judgment, abstraction, the frontal lobe symptoms. And this disorder should be progressive enough to change that person's quality of life. So this definition is at least 30 years old, but it still holds true. Often when someone tells us about memory, we need to ask them also about behavior. So we need to have a frontal lobe questionnaire. We need to ask about, is there a change in personality and behavior? Is there a history of aberrant planning? Is there a change which suggests that this person has a stereotype behavior? So if you have someone with a very dramatic frontal lobe degeneration, you give them one pair of glasses, they will put it on. You give them a second pair of glasses, they will stack it on the first. That's what we call stereotype behavior. You give them the third one, they will stack the third one. So they already have a pair of glasses, they don't need the second and the third. But this is stereotypy. It means it's not stereotypy, but it's stereotype behavior. It means that when a stimulus is given, that person will. So in the old days, 35 years ago, we had clinics where a patient would be taken in broad daylight at 1 in the afternoon to the bedroom, and the British person would put on the pajamas and go to bed. Well, it's not the time of the day for bedtime, but they would actually go to bed and they would demonstrate that there is a frontal lobe dysfunction. History of aberrant behavior, history of circumlocution. They are conversing, but they can't get to the point. They talk about everything except what needs to be discussed. So that is important. A history of impaired recognition of cause and effect. I had a patient many years ago when I was a student, like before Aditya's time, of an individual who was coming, the story was that they were coming from Indore, and he got off at the train, the station in between, when the signal had already turned green. So the train was about to depart and he decided he wanted to have water. So the son actually said that, my father doesn't have judgment. The signal had turned green, he got off to have water and he missed the train. So we had to get off at the next station and come back to pick him up. So recognition of cause and effect is an important executive function, and it resides in the frontal lobes. It's part of the frontal questionnaire. And then, of course, there has to be a history of gait dysfunction, of seizures sometimes, and incontinence, because the deep parts of the frontal lobe, the diencephalon, regulates important neural networks involved in the efficient maintaining of these systems. Then there is this enigmatic part of the frontal lobe called the cingulate gyrus. You've all heard about it. That's your cingulate gyrus, located here. And this cingulate gyrus is the neuronal hub for goal-directed motivational behavior. If somebody has dysfunction in cingulate, you have decreased spontaneity, decreased productivity, decreased initiative, lack of ambition, and there is something that you call pathological inertia. That means that person can't get anything going, and there is a lack of follow-through on any plan. Now, you'll often hear a story like this. So, I know that this is a cingulate symptom. Now, what I've learned in the last 5 years in dealing with people with sleep apnea is that there are many individuals with sleep disordered breathing who will come with this entire thing. Their brain scans may be normal, but one of the dominant features, so even just not breathing well in your sleep can take away the efficiency of your cingulate functioning. Then one should have a parietal lobe questionnaire. You need to ask about language dysfunction. Is the person using words well? Are they paraphrasing? Are there a writing dysfunction? Is there a reading dysfunction? Is there a change in the mellifluousness of speech and prosody? So mellifluousness of speech and prosody is a non-dominant parietal lobe function, important. Is there a change in cortical sensations? Once in a while, you can have an individual who has such a dramatic change in cortical sensation that they have an alien hand where the hand is sensorily deafferented and it doesn't know what it's doing. So it's constantly moving. And we call that the alien hand syndrome, a very typical symptom of a neurological condition called corticobasal ganglionic degeneration, which we think is a kind of overlap with frontotemporal dementias. Then there can be history of auditory agnosia. There can be a history of apraxia, reflected in not being able to dress. They give them a pair of pajamas, they don't know where to put their feet. And they're trying to wear it in their upper torso. And the use of gadgets. History of inability to perform calculations and simple math. So this thing has to be in our historical questionnaire. If we don't ask, we're not going to get them, because the patient's family does not think that this is relevant. So having a repertoire of questions to ask is an important thing. And of course, history takers can be of various kinds. In my experience over time, we have all kinds of students who are history takers. You have the wanderer or the vagabond history taker who is flip-flopping from 1947 to 2020 and not able to get to the point. You can have someone who's a garbage collecting history taker, who takes everything under the sun that the patient says and piles it into the notes. And you read those 2 reams of paper and you're saying, what do we have here? We have nothing, right? So you can't have that. Then you have a tight-fisted history taker who says, patient has memory problems, now is incontinent, come to OPD. End of story. So this is the tight-fisted Trappist monk who doesn't really want to take a great initiative in getting this there. But what we really want is you will need a gifted history taker who has the inspired dedication of a microbiologist, because your history is a verbal picture of the patient's problem. When you read that history, it should tell you where in the brain is the disease, what is the likely pathophysiological mechanism, and what is the current functional abilities to perform activities of daily living. If it answers those 4 things, that's a good history. So you have people like that, the garbage collectors, and you have the Michelangelos. So every student has to learn that here is one place where history taking and putting it together into a form that is a delight to read is important. So here's someone, a 36-year-old Indian housewife, developed subacute onset of behavioral change associated with loss of immediate memory. She experienced paranoid hallucinations, believed that a group of men dressed in black clothes were stalking her. She even felt that they invaded her home and sat down at her dining table, incessantly demanding meals. She became confused, could not find her way around the house and neighborhood. She forgot the names of her children, the school where they studied, her home address, her telephone number, and the place where her husband worked. Her confusional state spontaneously remitted and relapsed. That's the temporal profile. A few days later, she became unsteady and staggered around the house, cerebellum. She experienced left facial-brachial focal seizures, so the focal symptom. With secondary generalization, was admitted in the hospital. She had no previous history of medical illness except for having been diagnosed to be hypothyroid a year ago and had been treated with 100 micrograms of Eltroxin since. She had no family history of major medical ailments, did not abuse drugs, and was a teetotaler. Right? So this tells you a lot of things. It tells you a clear painted picture. This is 1998. This is a paper that I wrote as a student for Dr. Wadia on the first Indian case of Hashimoto's encephalopathy. This was published in Journal of Neurological Sciences. So the neurologist in training, I think, needs to be made aware that Alzheimer, Lewy body disease, FTD, they are the common substrates of degenerative dementias. Rapidly progressive dementias, there's a separate subgroup, right? And some of them are treatable, and the most untreatable is CJD, it's known as prion disease, you know that. Patients can exhibit progressive impairment in domains of memory, language, visuospatial skills, executive abilities. So that's your take home. And clinical accuracy requires early evaluation, repeated assessments, astute history, ancillary input from imaging. You have Dr. Meher who is going to tell you today how every one of those images are going to be relevant to how we understand the clinical story. So that imaging is important, and pattern-specific distinctions can be made on the basis of all this. So to understand dementia, you need all this. That's the clinical part. So how successful is this? So here's an example. This is one example which I am very fond of quoting. This is Susan Schneider Williams. She is the wife of Robin Williams. Robin Williams passed away in 2014. Okay, this Susan Schneider, she started a fund for diffuse Lewy body disease because she must have seen more than a dozen neurologists in California, and her husband didn't have a working diagnosis. This is what she wrote. So she wrote an article in Neurology. This was a special editorial. She titled it, "The Terrorist Inside My Husband's Brain." And this is what she had written, that October 13, our second wedding anniversary, Robin had been under his doctor's care. He'd been struggling with symptoms that seemed unrelated: constipation, urinary difficulty, heartburn, sleeplessness, insomnia, poor sense of smell, and lots of stress. He also had a little tremor in his left hand, and that would come and go. So his neurologist didn't know what they were dealing with. He hated that he could not find the words that he wanted in conversations. So he had a word-finding difficulty where he wanted to speak and he couldn't find the word. And you know what a wonderful actor Robin Williams was. He would thrash at night and still have terrible insomnia. So what is this thrashing at night? He had REM sleep behavior dysfunction, and he still couldn't sleep. At times he would find himself stuck in a frozen stance, unable to move, and frustrated when he came out of it. He was beginning to have trouble with visual and spatial abilities in judging distance and depth, and his loss of basic reasoning just added to his growing confusion. And I kid you not, Robin Williams did not have a working diagnosis till he died. And when his brain was given to autopsy by Susan Schneider because she wanted to know what was wrong with my husband, they found diffuse Lewy body disease. So this can happen in America. And that's why fora like these are important, because if we don't get together to learn how we are going to approach this process of making a valid working diagnosis, everything that we have discussed so far is going to be important. Okay, so we know that he had all these symptoms. He had visual hallucinations, he had REM sleep behavior dysfunction, he had a bit of Parkinsonism, and there was fluctuating cognition. These are all core features. These are in the criteria for diffuse Lewy body disease. Ian McKeith and colleagues, Ian McKeith is a psychiatrist, as you know, from Newcastle. So if you have younger people, then we discussed language and behavior. And language and behavior often can be lumped together in varying nuances in frontotemporal dementia, and Aditya is going to talk to you about that, because there is a tendency for the dysfunction to be localized for a prolonged period of time within a very regional part of the dominant or the non-dominant temporal lobes and the frontal lobes. So what's happening to these elderly people? Why do we lose it if we grow older? So here's Joy Desai standing on the dais and talking to you. What do you think can happen as I grow older? Well, the question to ask is that these dementias, are they an exaggerated and an anomalous exaggeration of the process of aging compounded by aberrant pathology, which then snowballs into a dysfunction? We don't know that, but I certainly believe that there could be a component of age-related change in neuronal functioning efficacy, all the things, neuronal cells, the neural networks. As we age, they could become dysfunctional. So what do we know about that? So Lopez-Otin is 2013 first paper on the hallmarks of aging, and now 2023, 10 years down the line, 2 years ago, this is the new one that's been written. 2 other additional things have been added. But what they have actually said is that how does a cell age and how does a neuron age? So the aging process is characterized by genomic instability, attrition of telomeres, homeostasis, disabled or dysfunctional autophagy. So we know that our cells have an inherent ability to clean, and dysfunctional protein elements are thrown out of the cell by a cleaning process called autophagy. And autophagy can be of 3 types. You learned that in med school in your first year. Microautophagy, macroautophagy, and chaperone-mediated autophagy. All of them can be dysfunctional. Then there is mitochondrial dysfunction. There is cellular senescence. We'll come to that in a bit. There is stem cell exhaustion, and there is chronic inflammation. And along with that is dysbiosis. Dysbiosis is the new thing that's been added. So the gut-brain axis, and I'm sure Aditya will talk a little bit about that, is that changes in our gut also determine how our brain behaves. And you can see that in all our patients. Often I see patients who have dementia and they come to I have some residents who are sitting here, they know that they come to the EMS saying that they are suddenly confused in the last 2-3 days. And they have a distended colon, you empty their colon and they get back to normal. So there is a gut-brain relationship, which is now the focus of intense neuroscience scrutiny, and we'll learn more about how looking after the gut. We'll talk about that in prevention. So essentially in aging, what's happening is that there's a greater amount of waste produced because proteostasis is anomalous and autophagy is dysfunctional. So greater waste, poor excretion, and hence accumulation. So the accumulation can occur in neuronal cells. It can be of various kinds. So this is the current understanding of what happens to a senescent cellular biology, not just within the brain, but also in our different organ systems. And this is the intense focus of research. So cellular senescence is characterized by something called senescence-associated secretory phenotype. That means older cells are sick enough to spontaneously produce inflammatory cytokines. And these inflammatory cytokines then make a surrounding cell, which is perhaps not older, inflamed. And repeatedly in the story of dementia and degeneration, you're going to hear that a degenerating brain is characterized by a chronic inflammatory state. So where does this inflammation come from? This inflammation comes from aberrant microglial function. We're going to talk about that too at some point. And the fact that this is an older brain. So older brains are susceptible. Can we do something about this? I have some thoughts on this, but we don't have enough information. So what's the neurological substrate? The substrate is this. Aditya will tell you that in Alzheimer's disease, there is accumulation of what was called originally senile plaque. This is beta amyloid stuck in the interstitium of the brain, and it is characterized by associated debris. So there are astrocytic debris, there are activated microglia, and in the neuronal cell, there is accumulation of phosphorylated tau. And these two things have been taught to us all the time since the time that it was described. Important thing, I think, that drives dementia is loss of synapse, neuronal atrophy, loss of function. And in about 1/3 of patients, there is also amyloid accumulation in the arteries called congophilic angiopathy. Now, the question is that the lobar topography of this determines the sequence of events. So the way the patient presents to you depends on where this is accumulating. And we know some things about it, but there's a lot that we don't know. We know that the topography of this so-called tangles shown here, the neurofibrillary tangles characterized by accumulation of phosphorylated tau, and the extracellular amyloid beta. The loci where it starts, this starts locus coeruleus, this is in the basal nucleus of Maynard, and its spread is topographically different. And though both are thought to be interrelated, this entire story of Alzheimer's is muddied by the fact that we don't know why different brain parts have this accumulation. So when you do a scan that I think Meher might tell you about, a tau PET or an amyloid PET, different parts of the brain actually light up on those. So really what is happening in the Alzheimer brain is a multifaceted dysfunction in neuronal functioning. So there is change in its vascular mechanisms, there is change in inflammation, the intestinal flora have changed, and we know that one of the contributors is, you may have heard that there are stories that if you have bad gum health, your dementia risk is higher. So there is an organism called Porphyromonas gingivalis. If that is the infection that you have in your gums, then it can accelerate dementia that you have. So we are trying to learn how most of these bodily dysfunctional systems are perhaps interconnected, but there's a lot that we don't know. Clear thing is that everyone has been attributing Alzheimer to amyloid and tau, but there is also this change in autophagy and there is a change in functional mitochondrial health. And this mitochondrial health is what you are actually measuring on an FDG PET. There may be many here in the audience who have done an FDG PET for patients. Your FDG PET is glucose uptake and that needs mitochondria. So the mitochondrial dysfunction is again a focus of research, and we don't know how this dysfunctional mitochondria add up to the Alzheimer risk. So what you have in the last couple of slides is that we have this risk for Alzheimer's disease, and we'll talk about this finally in the end. So sedentariness, cognitive inactivity, an unhealthy diet, poor quality of sleep, and important here is social isolation, lack of intellectual engagement, pollution, and you have some genes. You have ApoE carrier status, you have APP, presenilin 1, some of it will be discussed by Aditya, some a little later by me. If all of these can be, and network hyperexcitability, so if you have a lot of chronic stress, then network hyperexcitability in a stressful state becomes the biological bed on which degeneration can start. So these are our susceptibilities. But we also have resilience, and we can build on our resilience. So what are the factors that we think that can build our resilience to the ravages of time and the tax you pay in the brain? Developing Alzheimer, I think physical activity, cognitive activity, a healthy diet, we'll talk about that, good quality sleep, much more than that, social network, very important, education, low air pollution, and an intact default mode network. So if you're calm, if you are meditative, then your default mode network is not going to be susceptible. If you're chronically stressed and you're a ruminator, which all of you in the psychiatry world knows a ruminator, your default mode network is never going to be normal, right? So these are the things we know. So before I sign off, and just a couple of things, we will learn today that the vulnerabilities in the aged are many. They are somatic, musculoskeletal, the hallmarks of aging, cellular effects of senescence, and this is compounded by ravages of unknowing lifestyle neglect. So not moving is a lifestyle neglect. Eating wrong is a lifestyle neglect. Drinking too much is a lifestyle regret. Smoking is a lifestyle neglect. Sleeping late is a lifestyle neglect. Just imagine that nobody taught you this in med school. Just sleeping late is gradually whittling away your neurological reserve. Go home and think about what we said. We now know, Diego Carvalho's study, that if you're sleeping 2 hours less on a regular basis, your risk of Alzheimer's disease is going to go up by 40%. So think about that. So the clinician dealing with dementia requires comprehensive understanding of neurobiology, clinical disease patterns, imaging correlates, and the influence of lifestyle factors. So you need everything. And of course, you need colleagues like Meher and Aditya who are going to help you with all the ancillary information that's relevant to come out. And every advance is tempered by the understanding that resilience promotion may pay much richer dividends than treating pathophysiology. So Aditya is going to talk to you today about what we give our patients, what's in the wings, and a lot of what's in the wings is not very satisfying. And he's going to talk to you about that. So where are we? We are at the cusp of also a revolution in understanding resilience. So those who are fond of Greek history may have heard of the Moirae. They are the Fates, and there are three of them. There's Clotho, there's Lachesis, and there's Atropos. So Clotho spins the thread of life. Lachesis determines the length of the thread, spreading joy and sorrow, according to the Greek mythology, and Atropos cuts the thread to determine the time of death. So why is this relevant? It's relevant because we have discovered a protein called Clotho. And this Clotho is now a focus of intense neuroscience research. What they're saying is that it regulates autophagy, it's important for clearance of amyloid beta and phosphorylated tau, it mitigates neuroinflammation, and it enhances cognitive functions, and it's got anti-aging properties. It protects your kidneys from chronic kidney disease. It also has a role to play in diabetes and pancreatic health. So this Clotho has taken neuroscience world by storm. The reason this got discovered is because if you had a variant in the Clotho gene, it is called the Clotho VS gene, shown here. If you had a variant in the Clotho VS gene, it can even protect you despite having copies of epsilon E4. So the traditional teaching is that if you're an older person, you have Joy Desai here, he's got 2 copies of epsilon E4 ApoE in his genetic makeup. It enhances my dementia risk, like Chris Hemsworth, to about 15 times normal. If you have 1 copy, your dementia risk is increased by 3 times normal. However, if you have a Clotho gene, it can mitigate that. So here's where I want you to understand that resilience is equally relevant. We are all talking pathology, but is everybody destined to go down this road? I'm not so sure. So how can we increase Clotho? Well, they say that cordyceps mushrooms, and if you go to Bhutan, how many of you have been to Bhutan? So you will find that there are shops that sell cordyceps mushrooms, right? You may have seen them. So cordyceps mushroom is, again, in traditional medicine, thought to be anti-aging. And now there is information that cordyceps mushrooms may increase Clotho. And we have some new data just about a few months ago that intermittent fasting improves Clotho levels. So there is a lot of work going on. I think there's a big center in California that's looking at this. And we're going to have a talk about diagnostics, blood testing, and the actual journey that a patient undergoes in the clinic. I thought today my job was to introduce to you what happens when the patient comes to the clinic, what the basis for what's going wrong in their brains. And then Aditya is going to walk you through those patterns. Meher is going to talk to you about radiology. And then we try and understand whether we really have something of value in therapy. And perhaps the sad answer is that probably not. We don't have anything really of value that can stop the disease in its tracks, out of question. Do some patients get better? Some do. And there are going to be medications. You're going to hear about the behavioral symptoms, and you'll hear about anticholinesterase inhibitors, acetylcholinesterase inhibitors, and you'll hear about anti-glutamate therapy, and some of the newer therapies that are in the wings. I'm going to stop here, and do you want to do questions now or in the end?